This lecture will go over hyper and hypoparathyroidism. First, we'll start off with hyperparathyroidism. The parathyroid glands maintain calcium and phosphate balance. Serum calcium level is normally maintained with a narrow range. Increased levels of parathyroid hormone, or PTH, act directly on the kidney, causing increased kidney reabsorption of calcium and increased phosphorus excretion. In hyperparathyroidism, this causes hypercalcemia, excessive calcium, and hypophosphatemia, inadequate phosphorus. In regards to the bones, excessive PTH levels cause calcium and phosphorus levels in the blood to become higher, while calcium and phosphorus levels in the bone to decrease. This results in reduced bone density, placing the patient at increased risk for fractures. With chronic calcium excess and hypercalcemia, calcium is deposited in soft tissues. The most common cause is a benign tumor in one parathyroid gland. In terms of assessing, symptoms of hyperparathyroidism may be related to the effects of either excessive PTH or the accompanying hypercalcemia. Ask about bone fractures, recent weight loss, arthritis, or psychological stress. Ask whether the patient has received radiation treatment to the head or neck. The patient with chronic disease may have a waxy pallor of the skin and bone deformities in the extremities and back. High levels of PTH cause kidney stones and deposits of calcium in the soft tissue of the kidney. Bone lesions are caused by an increased rate of bone destruction and may result in fractures, bone cysts, and osteoporosis. GI problems such as anorexia, nausea, vomiting, epigastric pain, constipation, and weight loss are common when serum calcium levels are high. Elevated serum gastrin levels are caused by hypercalcemia and lead to peptic ulcer disease. Fatigue and lethargy may be present and worsen as the serum calcium levels increase. When serum calcium levels are greater than 12, the patient may have psychosis with confusion, followed by coma and death if left untreated. Serum PTH, calcium, and phosphorus levels and urine cyclic adenosine monophosphate levels are the lab tests used to detect hyperparathyroidism. Please see chart 63-10 and review the common lab values seen with hyperparathyroidism. X-rays may show kidney stones, calcium deposits, and bone lesions. Loss of bone density occurs in the patient with chronic hyperparathyroidism. Let me say that one more time. Loss of bone density occurs in the patient with chronic hyperparathyroidism. Surgical management is the treatment of choice for patients with hyperparathyroidism. For those who are not candidates for surgery, drug therapy can help control the problems. In terms of non-surgical management, diuretic and hydration therapies help reduce serum calcium levels in patients who have milder disease. Usually furosemide, a diuretic that increases kidney excretion of calcium, is used along with IV saline in large volumes to promote calcium excretion. Drug therapy for patients who have more severe symptoms of hyperparathyroidism or who have hypercalcemia related to parathyroid cancer involves the use of cinacalcet. When taken orally, cinacalcet drug binds to calcium-sensitive receptors on the parathyroid tissue, reducing PTH production and release. The result is decreased serum calcium levels, stabilization of other minerals, and decreased progression of PTH-induced bone complications. The patient's serum calcium level must be monitored for hypocalcemia on a regular basis for the duration of the therapy. For patients who do not respond to cinacalcet, oral phosphates are used to inhibit bone resorption and interfere with calcium absorption. IV phosphates are used only when the serum calcium levels must be lowered rapidly. Calcitonin decreases the release of skeletal calcium and increases kidney excretion of calcium. It is not effective when used alone because of its short duration of action. Therapeutic effects are enhanced if calcitonin is given with glucocorticoids. Monitor cardiac function and INO every 2 hours during hydration therapy. Monitor serum calcium levels and immediately report any sudden drop to the primary healthcare providers. Sudden drops in calcium levels may cause tingling and numbness in the muscles. Also, monitor for changes in ECG tracking. Preventing injury is important because the patient with chronic hyperparathyroidism often has significant bone density loss and is at increased risk for fractures. Surgical management of hyperparathyroidism is a parathyroidectomy. Before surgery, the patient is stabilized and calcium levels are decreased to near normal. All 4 parathyroid glands are examined for enlargement during surgery. If a tumor is present on one side, but the other side is normal, the surgeon removes the glands containing tumor and leaves the remaining glands on the opposite side intact. If all 4 glands are diseased, they are all removed. Nursing care before and after surgery, surgical removal of the parathyroid gland is the same as that for thyroidectomy. The remaining glands, which may have atrophied as a result of PTH overproduction, require several days to several weeks to return to normal function. A hypocalcemic crisis can occur during this critical period, and the serum calcium level is assessed frequently after surgery. Check serum calcium levels whenever they are drawn until calcium levels stabilize. Monitor for indications of hypocalcemia, such as tingling and twitching in the extremities and face. Check for Trousseau's and Volstex signs, either of which indicate potential tetany. Laryngeal nerve can be damaged during surgery. Assess the patient for changes in voice pattern and hoarseness. When hyperparathyroidism is caused by hyperplasia, tissue overgrowth, 3 glands plus half of the 4th gland are usually removed. If all 4 glands are removed, a small portion of a gland may be implanted in the forearm, where it produces PTH and maintains calcium homeostasis. If all these maneuvers fail, the patient will need lifelong treatment with calcium and vitamin D because the resulting hypoparathyroidism is permanent. Hypoparathyroidism is a rare disorder in which the parathyroid function is decreased. Problems are directly related to a lack of parathyroid hormone secretion or to decreased effectiveness on parathyroid hormone on targeted tissue. Whether the problem is a lack of PTH secretion or an ineffectiveness of PTH on tissues, the result is the same: hypokalemia. Hypoparathyroidism can result due to the removal of all parathyroid tissue during a total thyroidectomy or surgical removal of the parathyroid glands. It can also occur spontaneously. Hypomagnesemia or decreased serum magnesium levels may also cause hypoparathyroidism. Low magnesium levels are seen in patients with malabsorption syndromes, chronic kidney disease, and malnutrition. Low magnesium levels suppress PTH secretion and may interfere with the effects of PTH on the bones, kidneys, and calcium regulation. In terms of assessing, ask about the patient, ask them if they've had any head or neck surgery or radiation therapy, because these treatments may injure the parathyroid glands and cause hypoparathyroidism. Ask whether the neck has ever been seriously injured, such as in a car accident or by strangulation. Assess whether the patient has symptoms of hypoparathyroidism, which may range from mild tingling and numbness to muscle tetany. Tingling and numbness around the mouth or in the hands and feet reflect mild to moderate hypocalcemia. Severe muscle cramps, spasms in the hands and feet, and seizures with no loss of consciousness or incontinence reflect a more severe hypocalcemia. The patient or family may notice mental changes ranging from irritability to psychosis. The physical assessment may show excessive or inappropriate muscle contractions that cause finger, hand, and elbow flexion. This can signal an impending attack of tetany. Check the Volstex sign and Trousseau sign. Positive responses indicate potential tetany. Here's a visual reminder of Trousseau and Volstex signs. I remember Volstex signs because it starts with a C, whether you want to call it Volstex, however you want to pronounce it. But I think of the C and it reminds me it deals with the cheek. And the other is Trousseau sign. And again, it's that muscle contraction, is a sign and symptom of hypocalcemia. Bands or pits may encircle the teeth, which indicates a loss of tooth calcium and enamel. Diagnostic tests for hypoparathyroidism include EEG, blood tests, and CT scans. EEG changes revert to normal with correction of hypocalcemia. Serum calcium, phosphorus, magnesium, vitamin D, and urine, cyclic adenosine monophosphate levels may be used in the diagnostic workup for hypoparathyroidism. Again, please review chart 63-10 to find the abnormal lab findings that go along with hypoparathyroidism. So in terms of interventions with hypoparathyroidism, we have three things that are low: calcium, vitamin D, and magnesium. So those are our interventions. To correct hypocalcemia, the patient will be administered calcium chloride or calcium gluconate. Acute vitamin D deficiency is treated with calcitriol. Hypomagnesemia is treated with magnesium sulfate. Long-term oral therapy for hypocalcemia involves daily intake of calcium and vitamin D supplements. Nursing management includes teaching about the drug regimen and interventions to reduce anxiety. Teach the patient to eat food high in calcium but low in phosphorus. Milk, yogurt, and processed cheeses are avoided because of their high phosphorus content. Stress that therapy for hypocalcemia is lifelong. Advise the patient to wear a medical alert bracelet. With adherence to the prescribed drug and diet regimen, the calcium level usually remains high enough to prevent a hypocalcemic crisis. Now we'll review the end of the PowerPoint practice questions. Go ahead and pause the video to read the questions and then decide on your answer before resuming the video to hear if you indeed chose the correct answer. So for this first case study question, the correct answer would be rule out hypothyroidism. Most cases of hypothyroidism in the U.S. occur as a result of thyroid surgery and radioactive iodine treatment for hyperthyroidism. The correct answer for the second, the correct answer for the second case study question is D. The correct answer for the third case study question is D. Although I will point out you won't see synthroid on your test questions or on the NCLEX. You're going to see levothyroxine. The final case study question, select all that apply. The correct answers are B, C, D, and E. Answer to question 1 is A. Answer to question 2 is A. Answer to question 3 is A.